Well, thank you very much. It really is a privilege to have the chance to share some thoughts with you from the perspective of our academic health centers and our specialty hospitals, and particularly to share the panel with Chairman Walsh and Secretary Bigby, who have worked so hard to master the complexities of our particular part of the healthcare enterprise in figuring out how to move the process, a much-needed process of both health care reform and payment reform forward. And I'm particularly grateful for the opportunity to share the podium with Lynn Moore. And, Dr. Cox talked about headwinds. And part of the privilege I have in my career is walking through a lobby every morning where I see the people who face the strongest headwinds of all in healthcare, and that's the people who are faced with the diagnosis and coping with a serious disease. And people like Lynn not only deal with those headwinds, and their own issues, but then advocate for others who need that care. And I always believe are the true heroes in any innovation enterprise involving biomedicine, because nothing gets into practice unless it has been tested in clinical trials with patients who agree with risk, with no guarantee of benefit, agree to participate in those clinical trials so we can find out whether those agents that are being developed in our enterprise are actually going to be of benefit. So Lynn is a true representative of this ecosystem for innovation, as well as the reason that we're all here. So thank you for joining us. I'm here as a executive of an academic health center, but also as a physician, as an educator of undergraduates, graduate students, and postdoctoral fellows, medical students, residents, subspecialty fellows, nurse practitioners, physician's assistants in all those classrooms and all those bedsides, and as a molecular scientist who has developed discoveries and had some of those move into the space of intellectual property development. Also someone who's worked in several other states and healthcare marketplaces in New Haven, in Pittsburgh, and Baltimore, and Bethesda. And the remarks I want to make are colored by all those perspectives. First, let me say that those of us in the academic health centers welcome health reform. The idea now that virtually everybody in the state has access is an enormous good thing for this Commonwealth. Very different from what happens when many patients walk through the door in our other states. We also realize that this has created an enormous and potentially backbreaking cost for our community and our Commonwealth, and want very much to be part of innovations that will make health care cost-effective, appropriate, the services that get to the patients are the right ones at the right time for the right diagnosis, in the right dosages, and with the right amount of clinical surveillance and follow-up, and most importantly, with an eye toward prevention and early detection of illnesses, so those high-intensity care becomes the exception rather than the rule. But we are also an important part of the ecosystem, and that's where I'd like to focus today, because I think in the health care reform conversation, we're often thought of as the high-end, expensive providers of care, and there's correctness to that. But I think it also is important to remember that we're very important parts of the ecosystem. The Dana-Farber Harvard Cancer Center, which is a consortium of the Dana-Farber, 4 other principal teaching hospitals at Harvard, the School of Medicine and School of Public Health, accounts for $600 million of that $2.4 billion of federal funding. The Harvard Medical School faculty, and I could add to this Tufts and Boston University and University of Massachusetts, if I knew those numbers more precisely, accounts for somewhere between 10 and 15,000 faculty, most of whom are, in addition to taking care of patients, are training the workforce that goes to work in this broader biomedical enterprise, and are generating the discoveries and intellectual property that frequently become those startup companies and frequently become developed in the biotech and pharmaceutical industry. So at every stage, from proof of principle to startup company to biotech in second or third or fourth rounds of funding, and right on through partnerships with the large pharmaceutical companies, physician scientists are at the heart of that and are essential to that, and I would argue are a major reason that those companies are here. The generation of jobs just from that NIH funding alone, if you look at that $600 million I took you, which represents only a part of what academic centers, that's only the cancer part, that funding is about 60% personnel, high-paying, highly technical jobs, lab technicians, people who handle animals, people who handle purchasing, people who handle the actual conduct of the research, graduate students, postdoctoral fellows, and parts of the physician's salaries who also are providing clinical care. So as we think about the consequences and unintended consequences of healthcare reform, I think it's important to remember that part of the value that you get when patients receive care at an academic health center goes to this ecosystem as well, because we sustain within our own ecosystems the ability to have people who can devote substantial amounts of time, talent, and effort to discovery, to delivery of that discovery in practical forms that can then be developed into new innovations. One simple example of that is Gleevec, which was developed by scientists at the Dana-Farber and Novartis and MIT, very much a Massachusetts discovery. It has been a game changer in the care of patients with leukemia. For that form of leukemia, the only hope one had for treatment, and you would get about a 20% chance of it surviving, was bone marrow transplant at the best cost, $200,000. Gleevec right now costs about $20,000 a year to take as an oral medication. 90% of the patients get long-term remissions, some of them cures. By the time you have spent that $200,000 on that patient has gotten another 9 years of not just life, but very high-quality life, and many will get many more as the cost of that drug comes. And helping us think through ways that this complexity of the ecosystem by which we generate improvements in healthcare that are not only high-tech but have long-term, like Gleevec, a potential to make healthcare far more cost-efficient with a much higher quality of life and value, to recognize the complex interactions that go on between healthcare reimbursement, federal funding, the work of our faculties and staff, the education and research missions, and the ways that they feed into value for healthcare both directly and indirectly. Right now, the major challenges our part of this system face is that we are and are regarded as high costs, largely on the basis of price structure. That is already being reversed. As Chairman Walsh mentioned, Dana-Farber has also now for the past couple of years operated under contracts with the private insurers that have had little or no increases. In fact, our recent ones were 0 increases as well. But the challenge is utilization of services at whatever price. We believe that we can work with the government and with the payer community to show that when you have a system like ours with fully salaried physicians, with research going on, systems research, with the information systems that the chairman mentioned, we have those set up. If you come to the Dana-Farber, we'll know who you are. You may want us to just send you home, and we have people who work in health services research who serve on our faculties in addition to delivering care, that we can show that utilization of those services at whatever price is far more appropriate in our setting, where we have more coordination of care and in fact can be used to pilot and model and support research in the community and clinical care in the community to get there, to practice more fully according to expert guidelines, to take advantage of expertise to get the right answer first. So we're very anxious to be partners in this and hope that as the process proceeds, that we are able to find a way, as has been mentioned several times, to get from here to there without unintended consequences. When I travel around the country to my colleagues, I come home thinking that all of our academic health centers should give up our school colors and instead wear yellow, because around the country everyone tells us we're the canaries in the cave. And in a very real sense we are. The rest of the country is watching to see what happens to organizations like ours as we presage what will be going on nationally with the federal health care reform bill. So I think we have an opportunity both in our own Commonwealth but nationally to show how this can be done, how we can come out with a more cost-effective, better and more innovative health care system for people like Lynn and all of our families and friends, and someday ourselves, to receive better care. Thank you very much.